Thank you, and it's wonderful. I think today we have had wonderful speakers and also panel discussions. Also this morning we had the Health New Zealand, the Tifat Oral Health Forum on international collaboration. It's also a wonderful conversation between academics, but also policymakers, practitioners. So this session is about digital health and AI for Asian and other ethnic communities. This is a quite important topic, I think, because we are, recently, I think since last year, we have seen just so fast development, like ChatGPT, like other areas, So like Copilot, we are now using it now. So it's just fantastic to see the progress, over the past couple of years. So for health, what does that mean? So today we got three brilliant speakers who talk to us. The first one is from overseas. It's Professor Teo Ik Ing. So Professor Teo Ing is really a esteemed speaker, and he has got so much experiences in many areas. And Professor Teo Ik Ing is Dean of Salisbury Hawke School of Public Health at the National University of Singapore, and also a governing board member for the Regional Center for Tropical Medicine and Public Health Network for the Southeast Asian Ministers of Education. Professor Teo Ik Ing received his Bachelor of Science in Mathematics from Imperial College, and also his Master of Science in Applied Statistics and a Doctor of Philosophy in Statistics from the University of Oxford, 2001 and 2006. Professor Teo is the Vice President of the National University of Singapore's new Office of Global Health. This is a multidisciplinary whole of university effort to drive the university health engagement efforts on the global stage. I'd like to now invite Professor Teo Ik Ing to talk to us. Thank you. So just a moment, I think we couldn't hear you. Sorry, Professor Teo, we can't hear you for the moment. So we might need to manage the technical issue first. So we actually swap. So maybe we can now invite Michael to talk to us first, and then we can invite Professor Teo to talk to us. So Michael is general surgeon with subspecialty training in liver, pancreas, biliary, and renal transplant surgery. He is the only surgeon in New Zealand who has completed formal post-fellowship training in HPB, that's liver and biliary and renal transplant surgery. Michael graduated from the University of Otago and completed his PhD in surgery with University of Auckland. So that's for Michael. Just hope our system can work.
I think you're not supposed to see that presenter slide, but thank you, Dr. Zhao, for his introduction. And when I first got this honor to speak here, I looked at the list of speakers, and I think they're all very esteemed and very intellectual. And I'm claim myself to be a simple surgeon. How do I move the slide? Yeah. Thank you. So I've been invited to speak on AI in healthcare and how does it affect ethnic minorities. And as I introduced, I'm a general surgeon with a subspecialization in liver, pancreas, and also kidney transplant. So I do have a disclosure and hope this sounds actually well.
We have nothing to declare.
So this is what Ian's supposed to be. What is artificial intelligence? I had to relearn all this because artificial intelligence is simplistically using technology or computer to do what humans are supposed to do. So we define intelligence as coming from humans. So if they come from something else, especially a robot or system, we define it as artificial. So we are very egotistical. We think humans are the center of the universe, and we think everything revolves around humans. And what is general surgery? It is basically deals with a lot of conditions, specifically abdominal contents, breast, skin, and neck. And I'm very cynical. I'm a cynical surgeon. It's pretty much whatever conditions no one else wants to deal with. And that's come to general surgery. If you come to a hospital, if anyone comes with a facial issue, the ENT surgeons or plastic says no, then general surgery have to take it. We're kind of the lowest denominator for surgery. To talk about AI, there are 3 different types of AI. The first type is what we call a narrow AI. It's very simple. You input a command or an instruction, comes back with an answer. So the most famous is obviously Siri, and more recently ChatGPT. So these are just what we call narrow AI. As the next step up is what we call a general or strong AI. It's machine learning. So the computer or the program learns and based on its experience, decides on the next step. Okay, so it's machine learning. It's supposed to think and reason like a human. And the most famous example is Agent Smith. Right? So that's what machine learning is about. And the next step up is what we call a super AI. It actually surpasses beyond human intelligence. All right. So that is the pinnacle of AI research or development. And I actually just looked at this picture last night and I thought, this is hopefully not the end of the world where all human skulls dead by the eye. Is this AI? So this is, as you may know, what we call a robotic surgery. So Da Vinci is the most famous robotic surgery. This is not robotic. It's not by definition anywhere near robotic. Robotic means it do its own thing. This is a technology for surgeons to do an operation. Okay, surgeon sits with a coffee, generally, at this console, and the arms operate. So it's using wireless technology. So it's not really a robot. It's the surgeon still have to do its work. Because I'm a surgeon, I'm a clinician, I have to think about what a patient journey is. And because, as I say, I'm a surgeon, I focus on the operation side. So definition of a patient journey from a surgeon's point of view is defined as 3. Preoperative, before an operation, perioperative, around the operation, and postoperative, after the operation. We are very selfish, so we just base everything about our world. Because of my interests, and I like to operate, I like to cut things open, I'm sorry to say, I focus on intraoperative and how AI can help us. It can help identify anatomy. So you input a lot of pictures and images to a computer. It recognizes what the pattern is. All right? For obviously people sitting here, you might be worried that if a surgeon goes to operate on you and do not know what they're looking at, that is a bit of a problem. But what we're trying to tell them, especially for gallbladder operation, so what is the most common operation for a general surgeon is to take out your gallbladder. This green pipe drains the liver to the intestine. Okay, we're not supposed to damage it because damaging it is a big deal. We are taking this little organ out for gallbladder surgery if they've got gallstones or any other reasons or gallbladder cancer. This is a very nice picture of what a gallbladder looks like inside the abdomen. If I walk in as a specialist and I see this operation and I see this picture, I laugh because this is probably the best possible specimen for a trainee to do because that's as uninflamed as normal as you can get. But that doesn't happen in real life. If you have inflammation or if you have previous operations or things go wrong, that doesn't look like that. But if the AI has detected a pattern, supposedly this is what we're supposed to hear.
Bile duct about to be cut.
So that means it's supposed preventing us from cutting this main bile pipe. But as a liver surgeon, I'm interested in this. So liver cancers I deal with. In Japan, what they're proposing now is getting a CT scan on images of the patient's liver, all its blood supply, where the tumor is, and all the structures around it, and construct a 3D images. Okay, and when the surgeon's operating, they have a screen in front of them with a camera attached to the headlight, so that when they're cutting through the liver, they know exactly where the tumor is and where the structures are. Okay, so obviously, if Google Glasses, you can wear a Google Glass and you can start doing that, but that's only in development in Japan. Okay, so it's not for safety reasons, not I think worldwide yet. Can I move the next page? Sorry. I was not working. Okay, so because I'm a holistic clinician, I think about the patient when they leave hospital. So this is what it looks like for AI to develop someone to look after you after your operation. And I don't think this is made in Asia because they're using a Dyson vacuum cleaner, by the way. But I think Japan and Korea is leading the way in developing robots, especially in Japan. If you go to restaurants and lots of places in Japan, they have robots taking over jobs from the waitresses and serving people. So going back to other parts of surgery, this is what we always joke, is as you go through med school, as you go to as a junior doctor, how do you decide what you want to be when you grow up? Okay, you start at the top, what's the problem? And if you like nothing, and how are your grades? Do you like to cut things? You say yes. And if you like strip clubs, you got orthopedics. If you like driving around luxury car around Los Angeles, you go to plastic surgery. So that's what I think. It's hard for us as clinicians to tell students what to do. My advice for a student is go through med school, enjoy every single thing you do, and rule things out. Don't go in with the set mind of saying, I want to be a plastic surgeon, I want to be a cardiac surgeon, because as a student, your experience is very different is when you become a junior doctor, because the student gets all the very fun stuff, go to clinic, go to operating staff, don't have to worry about the admin work. And what does this actually mean for ethnic minority? Obviously, congratulations to this organization for winning the Asian Ethnic People's Health Awards. Health inequality is very predominant worldwide. It's a complex and multifactorial issue. If it's as easy as spending more money, then it would be solved. But it's not as simple as that, as you all know. Minorities have worse outcome. Okay, they're marginalized. There are two different aspects of why they have worse outcome. In my simplistic view, is that one is they don't actually have access to resources. They turn up to the hospital thinks they're low priority, you can't get access. The second part is actually they don't actually have the ability to get access. They don't have a car. I have patients without a car to come to the hospital. They don't have money to go to the GP. And that's why emergency department is filled. So these are the two things that we have to address in our research. And how does AI help? Do you think AI is going to be the hero and save the world? Unfortunately, no. Going back to a patient journey, okay? I focus on the patient because I'm very simplistic. But the patient is only a very small part of a patient in the healthcare system. Okay? That's a very small part. If you look at any hospitals, everything else takes so much space that patients are only a little part. And I'm sure you look in the media, they all argue about budget cuts and funding cuts and who is a front line, who's not front line. I'm going to be very cynical again, is that the policymaker have never probably worked in the hospital before. They've never seen what it's like in front of patients when they come and say, I've waited 3 months to see a GP. I've waited 6 months to see a specialist in hospital. I've had patients wait 18 months to be referred from a GP to see a specialist for a simple benign condition. Okay. So in primary health, there's lots of parts where we can have AI help, and this is social determinants, different parts, but I break it down to very simplistically direct patient care. How can AI help us in deal with patients? The very first part, I'm sure a lot of GPs have started using this, is dictation software. The doctor talks to you, they have a recorder going, it just records the consultation. I think that's very good because it allows the GP to focus on speaking to the patient. Used to be 15 minutes, see a patient, write your notes, you have to get out of the room by then, because that's the slot you're allowed to by a patient, unless you double book yourself and you pay twice the price. I think this is very helpful for the GP. Translating software, obviously, that's very helpful for our ethnic minority who don't speak very much English at all, especially with the elder generations. I can speak Mandarin, I can speak Cantonese, and that's very helpful. But when I first started, I wasn't very confident in using medical terms. I had a translator come in. I can understand obviously the lingo. I speak 3 sentences to the patient. He translated 1. I was like, I'm sure that's not what I said. So maybe it can improve accuracy. Okay. Yeah. And there are algorithms for decision making. Okay. They are learning now where you put a patient's diagnosis or symptoms, and it comes up with a plan and helps make it a plan for you. But unfortunately, there's a lot of racial bias, because if you search this, it's what a housekeeper looks like. Right? So there's a lot of racial bias in algorithm. And it also lacks what we call experience or gut instinct. Okay. We train to be specialists not just because of reading books. You want to have a clinician, not just a surgeon, who understands what you're going through, when to operate, when not to operate. The hardest thing I tell the junior staff is when not to operate. Decision to operate is easy. I'm sure you've seen memes and jokes about orthopedic surgeons taking patients to theater and they have got no heartbeat and they're dead. But that's teaching a trainee or junior staff when not to operate is the hardest thing to teach them, because they all want to operate. They all want to do things, but that's the hardest part. AI have got lots of potential to addressing health inequality. It processes so much data. I'm sure I've done my PhD as well in the University of Auckland. I've done research, and it's hard work. It's slog. You type in, it used to be Excel sheet. I'm sure you guys use different things now. It's that you physically have to do a lot of data analysis, but an AI can help you do that a lot faster, and it can uncover a lot of potential correlations that you never saw if you were doing it as yourself as a human. And obviously, we are hoping it will unravel a lot of novel correlations that can challenge what we know at the moment. We all think AI and humans are in argument, in fighting. But what we aim for is for AI to work together with humans. I know I love movies, I'm sorry. But if you look at this movie, if you don't know, it's Tony Stark from Marvel. He's dead, but he's coming back again as a different character. Yes, he works with the AI. The human is still in control of the AI. I think that's quite important to know, is that we have to be still in control of what the computer does. Okay, because the computer do not have conscience at all, because it's just a machine. That's the matrix anyway. Unique challenges of AI. It really depends on what humans put in the data. As I've always been told in research, crappy input equals crappy output. So if you input your data really badly, the AI will come up with the crappy program or result at the end. And ethnic minority are always underrepresented in our health data. Okay, so that's a problem, because if you look at Health New Zealand data, minorities' health outcome is not very good, because one is they might go back overseas to get treated, but they're not very captured very well in New Zealand. Equity. Okay, if it's not considered, again, it's a lot of bias there, especially for racial biases. I'm saying that as a surgeon, when I was in public hospital, when the government decided that we have to prioritize healthcare based on racial ethnic group, I was told that I had to operate on the patient because of his ethnicity, even though he's only waited for 1 month, and there are patients on the list waiting for more than 6 months. Okay, so it has to be equal. Right? It has to be based on needs and not just ethnic group. I'm probably one of the minority that says that. AI development teams, lack of diversity. A lot of it is going to be Caucasian. But obviously, you can't have all Asians and no Caucasians. You have to have a mixture. I think that's very important that you have both groups. And you have to have some sort of ethical guidelines and standards. And I think for us as clinicians, we have the Medical Council of New Zealand determining our ethics. And there is a lack of patient-clinician focus. We can't just rely on machines and not rely on humans. Some recommendations: simply, you have to design it ethically, represent it. I'm sure obviously lots of diverse group here, obviously involved ethnic groups in the development. And as I always mention, you have to have some sort of human aspect of healthcare. Okay? And you always have to improve yourself. You have to judge what you're doing. What we call, in our field, we have to audit ourselves every year. You have to select a field of your practice, judge your outcome based on the standard outcome around the world, and you get audited by your peers. That's our requirement to be accredited to the College of Surgeons. I think that's very important for any healthcare program to have that audit as well. Very quick summary, AI has a role in healthcare, direct patient healthcare in a wider community. Lots of potential, but also significant risk if we're not careful. And very inclusive in every single step. And if you miss a step of including ethnic minorities in the development, then your outcome at the end is going to be very different than what you want. So that's very important. Human aspect to surgery, and especially healthcare, is still very important. Medicine is an art form as well as a science. So obviously we've gone through thousands of years. Surgeons are still sort of, we call ourselves Mr. supposedly, because back in the days we were barbers in the English. So the physicians call themselves doctors and surgeons as Misters because they do not want us to correlate with them. And in my field, I think AI is going to be very important in patient care, in cancer, especially cancer. My aim, hopefully in probably not my lifetime, is if you take a blood test or a sample of the patient's cancer and you can put it to a program and tell us whether whether they need an operation. Because in liver pancreas surgery, especially pancreas, a lot of our patients don't actually survive more than 1 year, even after an operation. The survival after pancreas cancer is about 5% in 5 years. Hasn't changed very much. Okay. So if they can tell us whether I should operate and cause morbidity to a patient, that's very important. And 2, what chemotherapy drugs to give them, to tailor them. And I think, unfortunately, there are obviously not a lot of genetics and a lot of ethics about that as well. Cool. Thank you.
Thank you, Michael. That's great. I think really, AI has a lot of potentials, but also potential risk. So, and, healthcare is really, we need to have the human touch. So that's quite important. So let's try to see if we can link to Professor Teoh in again. Can we try that? Okay, I think we have to move to CK. So Dr. CK Jin, my colleague is a clinical director for the AI lab for Health New Zealand. So he's a former resident medical doctor at Health New Zealand, Waitemata, and he was able to witness the rapid digital transformation during COVID period and contribute a lot to COVID response for our country. And CK actually, because of that, I think CK currently is just leveraging data and AI to address the complex health challenges. I think that's quite important for us. So, in addition to what Michael talking about from a clinical perspective, I think CK can give us more insights in terms of governance. So let's welcome CK. Thank you.
Good day, everyone. Good day, everyone. I'm Chen Kai, but most people just know me as CK. I currently work as the director for Health New Zealand's AI laboratory. So just want to thank Li Feng for giving me the opportunity to speak here today. Thing is, AI has seen quite a lot of rapid advancements in the last few years. And within New Zealand, we are seeing a growing momentum around the use of the use of AI to help improve the healthcare system. The promise is exciting. However, we are also confronted with the challenges, and we need to ensure that the adoption of AI is done in a it's done safely, and that the benefits can be reaped by all populations or all community groups within the population. So today, I just want to focus on how this issue is being addressed within Health New Zealand. Cool. So AI has actually seen quite a lot of rapid advancements in the last decade. So it's being developed for quite a wide range of different contexts and different specialties. At the moment, it has potential to improve diagnostic processes, treatment pathways, and patient experience. So just some examples up on the slide. Currently available AI tools, they're able to detect over 100 radiology findings on CT or chest X-rays at or above the level of a human. AI is now being integrated within screening pathways to help detect or to help the screening process for breast cancers and diabetic retinopathy by acting as a diagnostic aid or to aid with great increased access to the screening services. Although large language models are relatively new technology, it's being implemented within the clinical context to aid clinicians to reduce administrative clinical burden. So turning a conversation into a structured note. So, however, as we embrace these new technologies, it's also essential to consider both the benefit but also the potential harms. Examples of mismanagement and have occurred overseas. So in the context of the US, AI tools have been implemented which have demonstrated to be racially biased, especially for the minority communities. Other examples include AI tools that have been implemented that misdiagnose certain medical conditions because the training data was not reflective of the entire population. And in recent times, large language models, they've demonstrated a propensity to generate racial and gender biased results, especially in the context for treatment advice or clinical decisions. All these examples highlight that these tools, when poorly designed or implemented, can amplify these existing biases, leading to unequal health outcomes. So when AI is introduced into the healthcare system without the right governance structure, the consequences can be quite significant. So in terms of health inequities, in New Zealand, Māori Pacific communities already experience increased burden of chronic diseases, shorter life expectancies, and reduced access to healthcare. When we extrapolate this to other population groups, including Asian and ethnic populations, if AI tools aren't trained on data sets that are representative of minority populations, or if they don't consider the unique healthcare challenges that these groups face, they may result in suboptimal recommendations or predictions that make the health inequities worse. It's also trust. It's actually quite a foundational element in healthcare. And the introduction of these AI technologies, they actually risk eroding this trust. So there are minority groups out there who already have concerns about systemic health inequities. These communities have a long history of mistrust when it comes to new healthcare technologies, often because past innovations fail to account for their specific needs or tailored towards their cultural context. So if these AI tools are perceived to be biased, especially if they result in worse health outcomes for these communities, the levels of distrust will only increase. Finally, there are ethical and legal implications that need to be considered. One of the key ethical considerations when using AI is that it will need to benefit all groups within the population, and that the risk also needs to be shared equally as well. You can't have a situation where one population group reaps all the benefit and then another, and the risk is carried by another. Also, under Treaty of Waitangi, the government actually has a responsibility to actively protect Māori health and ensure equitable health outcomes. This means that the deployment of AI in healthcare cannot be divorced from these obligations, and that any AI governance frameworks will need to be designed with the treaty at its core. So, despite the growing presence and the potential impact of AI tools, New Zealand actually currently lacks any formal regulations for these AI technologies, and we most likely won't have any anytime soon. This regulatory gap presents quite a big challenge for particularly when it comes to ensuring the safe, ethical, and equitable AI deployment. So recognizing that the potential benefits and harm of these AI tools, Health New Zealand saw the need to establish a governance group, which led to the formation of this group called the National AI and Algorithm Expert Advisory Group. So this group reviews, evaluates, and provides advice for research groups or project teams trying to develop or implement AI tools within the healthcare system. The membership is actually quite a diverse background, so we have representation from clinicians, ethicists, data scientists, Māori, and legal experts, and it's reflective of the assessment framework that we use to evaluate these AI tools. So this framework we'll talk about in the next couple of slides, we find that it's quite essential to evaluate these AI tools so that they've been properly vetted before being implemented into the healthcare system. So this AI governance framework, it was developed based off both internal and external research. And the framework itself, it's split into 9 different categories with questions that vary depending on the stage of AI development. Appropriateness is the central theme to everything. Often people think that AI is magic, it can solve all your problems, but it actually can't. Not every problem is suited for AI, and the technology can't be simply applied as a blanket solution to all the issues. So it will actually involve carefully examining the availability of data, understanding the clinical context, showing that the problem is well defined, and confirming that AI can actually offer meaningful insights or improvements over traditional methods. If that's appropriate, you can consider the other domains. Won't go into details about all the other kind of domains, but I'll just highlight the key areas. So from a consumer's perspective, there are 3 essential elements. So that's accessibility, well-being and safety, and clear communication. For AI to be effective and equitable, it must be accessible to all people. Accessibility involves ensuring that all community groups will have equal access and to the benefit that AI can bring. So at the heart of AI in healthcare is a goal to improve patient well-being. So AI actually must enhance the quality of care, improve health outcomes without introducing new risks or harm. So this will include rigorous testing, validation, continuous monitoring of these AI systems across all population groups. Effective communication is going to be key to ensuring that consumers understand how AI is going to be used in their care. This means providing transparent explanations about what AI system does, how the decisions are made, and how their data is going to be used. So from a clinical perspective, the personal empathetic aspect of care could be diminished if healthcare providers become too dependent on these AI systems. It is crucial for clinicians to maintain a strong patient connection, ensuring that the AI only complements their work rather than replaces that human element of touch. Also, AI tools should be designed to support clinical decision-making by providing insights, but they should not override the autonomy of clinicians or patients. Clinicians need to retain control over the final decisions and use AI as a guide rather than the final decision maker. So while these AI tools will offer powerful tools for enhancing diagnostic or treatment recommendations, there's also a danger that there could be over-reliance on these systems, which could erode human expertise over time. So healthcare providers still need to continue to develop and trust their own expertise whilst ensuring AI is used as an adjunct to, not a replacement for their clinical knowledge. So this, including Māori perspective in AI governance is quite essential so that the AI tools aligns with the treaty values and Māori values as well. So this requires embedding principles from Te Mana Rauronga, Māori data sovereignty, into the framework. So to list a couple of principles that's been embedded within our framework itself, concepts like rangatiratanga, which emphasizes the right of Māori to make decisions about matters affecting their communities, including the use of AI in healthcare. So we have quite a large representation of Māori within that group. Kotahitanga is about working together for the collective good. So these AI systems that's implemented in healthcare must be designed to benefit not just selected communities, but the population as a whole. Kaitiakitanga emphasizes the responsibility to protect and care for resources. In the context of AI, this means that Māori should have guardianship over data and that AI systems should align with these values. So whilst these concepts are targeted towards Māori communities, these concepts, when we apply it to the population as a whole, will benefit all groups within the community. So from an ethical perspective, transparency is actually quite a core principle in AI governance. AI systems, they need to be designed and implemented in ways that allow for clear, open communication about how they work, what data they use, and how that data and how the decisions are made. So AI systems, they should also support autonomy, not undermine it. Both patients and clinicians must retain the power to make informed decisions, and using AI as a tool to aid rather than as a final decision maker. Above all, AI in healthcare must promote well-being and safety of patients. This will involve rigorous testing, validation, and continuous monitoring of AI tools to ensure that they don't introduce new risks. So from an equity perspective, although AI has tremendous potential to improve healthcare outcomes, it also carries risk of perpetuating inequities, particularly for historically marginalized groups. Addressing bias and ensuring equity in AI tools are critical responsibilities in AI governance. So AI systems, they are quite often developed using historical healthcare data, which can be embedded with patterns of discrimination, unequal treatment, or systemic bias. So if an AI tool is trained on data that reflects historical undertreatment for certain populations, it perpetuates, there's a risk of perpetuating those inequities. So this reinforces this will actually reinforce existing healthcare disparities rather than correcting them. Also, with this bias, it's not just a one-time issue, it will require continuous monitoring. So AI models, they can change in performance over time as the population in which the AI is used, it evolves. So ongoing monitoring is quite crucial. Healthcare providers, developers, they need to develop a robust strategy for regularly auditing these AI tools with a clear mechanism for adjusting models if disparities are found. This may include revisiting training data, remodeling, or implementing corrective measures. So incorporating these equity considerations into AI governance ensures that the AI tools not only avoid harm, but actively contribute to reducing health disparities and improve health outcomes for all groups within the community. So although algorithm bias can perpetuate existing inequities, there are several mitigating strategies that can be adopted. So first, appropriate data collection, showing that the data collection methods are comprehensive and representative helps prevent biased outcomes. So it's quite crucial to gather quite a diverse data set, which is reflective of the population in which that AI is going to be used in. Regular testing, continuous audits are essential to identify and mitigate biases in AI systems, allowing for adjustments and improvements to be made to ensure accuracy and fairness. Transparency, accountability, clear documentation, and open communication about how AI algorithms make their decision builds trust within our community and patients as well. Lastly, human oversight is key. Integrating human oversight into AI systems ensures that AI's automated processes are reviewed and prevent inaccurate predictions from going unchecked. So, in conclusion, while technologies like AI hold immense potential to improve health outcomes, its adoption and implementation must be approached with caution, given the inherent risks. To fully realize the benefits of AI, it's essential that equity remains a fundamental principle, showing that advancements are accessible and advantageous for all individuals, regardless of their background or circumstances. Cool. Kia ora, everyone. Thanks.
Thanks, CK. It's great. Lot of ideas and thoughts and the governance and ethics, all those kind of things. I think now we need to try the PerfectIQ again to see if we can work out.
Thank you very much for the opportunity to share some of the experiences that we have from Singapore. And I think I have a couple of case studies that will highlight the importance of AI having local information and data to train the AI machine learning model, because how data that is obtained from overseas may not be immediately relevant. And I thought I would start off from a basis of what public health has always been about, because public health, we focus on 3 types of activities around prevention, around screening, and trying to manage complications for people with chronic diseases. That's, broadly speaking, some of the activities around public health. But underpinning some of these activities are health systems aspects around communications, around financing, and also trying to monitor for cost effectiveness and for effectiveness. So that's a very simple introduction to public health. And how we see machine learning, AI, data science, or broadly speaking, a bigger umbrella term of precision public health, are the following: that precision public health is trying to make use of data and machine learning to help to continue our business that I've highlighted previously. It is a new way that we do the core business of public health, which is what I've highlighted around the prevention, the screening and the control, as well as the health systems. So in the School of Public Health, in the National School of Public Health in Singapore, we see AI in public health to be in 3 aspects. The first aspect is really around the thought leadership, which is where we hear our speakers today talk about the governance of AI, as well as how we regulate and the ethical issues around AI. But at the same time, what are the use cases that governments or the community sector have already started using AI? And I highlight that AI in public health, it's different from AI in medicine. Although I know in many countries and many settings, this distinction between medicine and public health is actually quite poorly defined. And then the last part of the activity of how we see AI in public health is about evaluation, because not all AI applications are effective, are reliable, are cost-effective, have all this benefit that we talk about: environmental sustainability, cost savings, and so on. So that is where, when I come back to the business of public health, I will use 2 cases today to highlight how ethnicity or context specificity is important. The first is around screening, and that is very specific to the use of AI to help improve the efficiency in breast cancer screening. So how we currently perform breast cancer screening, or what I see as the existing workflow, is that a patient typically will go for a mammogram to get a density scan of the breast, and there are radiologists that needs to look through each of these scans properly and to annotate these images. And in the current proceedings in Singapore, we need 2 radiologists to go through the same set of images for 1 patient. And then after that, each of these 2 radiologists will independently prepare a report before they compare their diagnosis, and then to provide a recommendation on the treatment process. So this whole process in Singapore at the moment takes about 3 to 6 months. Now, the question is that if I'm looking at trying to treat efficiently and quickly issues around breast cancer, 3 to 6 months can be a very dangerously long time to wait, both for the patients as well as for the clinical care treatment. So it is highly inefficient. It could potentially be inaccurate because of having this 2 radiologist approach. And this is really where we now have a national strategy that combines all the key national partners in Singapore around the hospital providers, the primary care providers, as well as the Health Promotion Board that is driving the financing for the adoption of screening approaches. And what we have done is we have looked at many of these mammogram images to really understand how to annotate. But what we found was that this problem was actually already addressed in the Western world, in Europe, in North America. But the algorithm, the AI engine that has been developed, were not appropriately specific or sensitive enough for application in Asia because of a simple physiological difference between East Asian women and European or Caucasian women. The density of the breast actually differs quite significantly to the point that we can't just take AI engines and apply it to Singapore's context or an Asian context without having local learning data. So this is really where having the local learning data became very important. And with local learning data, we have been able to now establish an AI-driven engine that now just requires one single radiologist to look through the scan, and the AI model come in to augment, to guide the radiologist. So the radiologist actually decides on the basis of their own evaluation, and then to compare with how AI comes in to help guide this assessment. So overall, when we did an evaluation, it's not just the cost savings in terms of the time taken, but there is quite a significant reduction in the false discovery rates, as well as the both false positive rates, as well as false negative rates. So from that perspective, there is actually a lot of benefit that we have now gotten from using an AI approach. And because we have a learning database for East Asian and including Southeast Asian women, we are now able to approach this in a much more regional context, applying for permission to apply this in Thailand, Malaysia, Philippines, Taiwan, in India, and now in the process of getting approval from Australia and from Japan. So that is one example really highlighting how having the local contextual data is important if we think that now AI is going to help in a space, whether it is in public health or in medicine. Now, I give you another second example, which is really around trying to help guide the process of triaging emergency calls. So in Singapore, we have emergency call units, as every country does. The number to call is 995. There is typically this emergency response center that is set up to guide the responses, whether it is just the delivery of the summoning of ambulances to handle emergencies. But the problem with such emergency calls is there are many false positive calls, meaning people that could have been better served without an emergency approach. They could have gone to GPs, they could have gone to the hospitals themselves without having to trigger an emergency response. Now, being able to identify those false positives actually helps to save resources, and because of that, save lives, because you preserve a very scarce and important resource to really focus on the true positives. Those are the truly urgent and emergency cases. So what we have developed in Singapore is an AI assistant to guide the triaging of the calls. And what this AI assistant does is that we built it off years of record from the ambulance case records, from what the call centers, the interaction, the communications. We have all the transcripts that are coded up. We can link this call centers with medical records from the National Electronic Health Databases. Now, this becomes very powerful, and I'll explain why. Because right now, when we have a call, the person who is receiving the call taker, needs to prompt the person who have called for a series of information in order to understand whether this call is genuinely urgent and emergency, or is it a false positive. Now, the call taker needs to navigate the emotions, the language that is being used, as well as whether the call taker immediately has reference to the clinical history of the patients. Now, if we are able to build all of this together, you could see that we are able to triage the symptoms, getting the instructions to be given to the caller, asking about or linking up with prior knowledge on the patient's clinical history. This prior knowledge may not need to come from the caller if we have an ability to link it up with a national database on health records. And if we know that this person has prior history, the call taker can actually advise the caller on certain immediate steps that can be taken. So with that, I will show you an example. I hope this is clear on your side.
Hello, 911 emergency.
Hello?
Yes, sir.
I'm calling from Stevens Road.
Mm-hmm.
I'm having this breathing asthma problem.
Give me your address. Give me your address first.
Okay, I am sitting at the bus stop.
Okay, give me the bus stop number then.
0209.
40209. Okay, hold on. Let me key in for you the address, yeah?
Okay.
How old are you, sir?
I'm 52.
52. So you're having shortness of breathing.
Yeah, I'm an
Okay,
asthma patient also.
Okay. Okay, sir. I'm getting the ambulance for you, but I need you to stay on the line, yeah? I got a few. I need to collect a few information from you. Okay. You're an asthma patient, huh?
Sorry, I cannot hear. What is that?
You're an asthma patient, right?
Yes.
Okay. You have your pump with you? Inhaler?
Yes.
Okay.
but
Have you
I
started
tried-
using it?
I use it, but not so good.
Okay, understand, sir. Okay. Then after that, do you cough any blood?
Blood? No.
No, okay, can.
My plan cannot come out.
So that's why you feel breathless, huh? Okay, sir. Ambulance is already on the way. Just if let's say you get worse in any way, before arrival of the paramedic, you just call us back immediately for more instruction, can?
Huh?
Okay, if let's say you get worse, you feel that your breathing problem is getting worse, you just call us back immediately for more instruction, okay?
Okay.
Okay, sir, give me your IC number.
I'm Malaysian. You want my PIN number?
Can give me your PIN number.
Okay, it's
Mm-hmm. Mm-hmm.
So we've masked this part because
You
it's
are
personal
spoken by Matthew?
identifier.
Mr. what?
City.
Kitty. SIT.
It's
Okay,
Yeah.
your contact number, sir?
So as you can see, as the call taker is speaking to the caller, on the left side, there are a lot of information that are being auto-populated. A transcript is also being auto-generated. At the bottom, there are specific guidance to the call taker on what to prompt, how to prompt, and what information is needed, such that we are able to triage this accordingly, whether it's the P1 or up to P4 level patient. So this is the way that really we see how AI is able to augment some of the processes that we have in providing health services to the public. So I thought I'll end off and highlight that our chief engineer for AI is actually this morning, Professor Feng, who really has been driving a lot of the developments of AI in health in the Singapore ecosystem. So with that, I'll just end off with 3 points. That digital health AI, very useful to help the fundamental things that we are focusing on in public health. We are still focusing on the same things, but now AI is able to help us do it better. The second part is really important to evaluate because not all AI engines are useful, and we really need to focus on the effectiveness and cost effectiveness. The last part, perhaps very pertinent to the theme today, is the context specificity. It's extremely important when we start to think about digital health and AI approaches. So with that, thank you very much.
Thank you so much, Professor Teoh, and also all the speakers, Michael and CK. Thank you so much.